Good afternoon, everyone, or morning for some. We wanted to welcome you to this week's It's Worth a Shot presentation on long COVID and its effects on elders. Today marks the 86th It's Worth a Shot presentation. So we would like to thank you all for your continued support and your content suggestions. Next slide, please. So as we go through today and others, we want to just make a quick disclaimer that the information in this presentation may present some content by third parties. This does not mean that Mountain Pacific endorses or constitutes the recommendations for the content. Next slide, please. As always, we like to give you guys some updates on every week. And this one's in regards to the COVID-19, the vaccination, administration, and health insurance coverage. One thing to note on here is that we want to make you aware that it is okay to give the influenza vaccine with the COVID booster. So just for you guys to be aware of that. They are, and by they, I mean CDC is saying that there is no downsides to getting both at the same time. And then also we wanted to point out, in case you guys didn't know, there is a bridge access program. And that program allows those who may be underinsured or uninsured to receive that bivalent booster or the updated booster for COVID-19 at no cost. Next slide, please. And with that, here's where you can go and you can take a look and see where they're offering the COVID-19 vaccine. Additionally, you can also select the participating in Bridge Access Program, and that'll show you all of the facilities that are participating in which you can get the vaccine for little to no cost. Next slide, please. As always, again, to continue these webinars, we do like to hear what your guys' thoughts are and ideas for presentation. So please feel free to add in the chat or send us any webinar topics or clinician ideas that you may have. And we can definitely put those in our docket to present on as we meet every Wednesday. So with that, we do have a polling question for everyone this afternoon. So the polling question is, how often does your facility complete medication reconciliations? We have during comprehensive NDS assessments, upon readmission from hospital, upon admission to the nursing home, change of conditions, and others. Please feel free to put that in the chat. And we'll give everyone a few minutes here. Maybe get some more presentation or more participation. Right, we're seeing these numbers come in. All right, Mary, it looks like we got what we have for now. So it looks like upon admission to the nursing home is the front runner at this time. Okay. Next slide, please. So as we look, unfortunately, this COVID data shows that we are seeing an uptick in hospitalizations and deaths this week. So we want to just be mindful of that as we, I guess, go into our cold and flu season. This is something to keep track of and to be mindful of with your infection control processes. Next slide, please. All right, and again, here is the US map showing the change in COVID-19 new hospital admissions across the states. And we see here there is a lot of orange out there, meaning that there is more, I guess there is a substantial or moderate increase in those new hospitalizations. So just again, something to be aware of, to keep your feelers out for, and to just, again, tailor your infection control processes and your visitor processes as we see an increase in your region. So with that, we are fortunate to have Mountain Pacific's medical director, Dr. Kunzweiler, here today to present on long COVID-19. So again, thank you, Dr. Kunzweiler, for being here today, and I will hand it over to him at this time.
Thank you, Shay.
Yeah.
And good to be here. Good to be anywhere at my age. And as you mentioned, I am the Chief Medical Officer of Mountain Pacific. I don't let that go to my head too much, though, because I'm also the only medical officer at Mountain Pacific. And I was asked to talk a little bit about long COVID in the elderly, of which I am one. So it's a topic near and dear to my heart. Just when you think you're getting COVID burnout, the numbers start going up again and hospitalizations start going up, and it's still here. We still have to worry about it. We still have to deal with it. So we'll talk about that. I've talked to some of my friends. My career was predominantly in the ER, so I talked to some of my ER friends and urgent care friends, and in the Helena area, they are definitely seeing a big uptick in people who are positive for COVID. They don't seem to be particularly severe, at least not at this time. They're not seeing a lot of people with low oxygen levels, but definitely seeing an increase in numbers. That's always worse.
You can go to next slide, Mary.
Yeah, next, there we go. Oh, so the definition, an acute COVID illness, scientists have agreed, lasts for up to 4 weeks or so. A little bit longer than a lot of other upper respiratory viruses, but certainly not unheard of. And for most people, the duration is less than that. 10 days to 2 weeks of significant symptoms is more common. So when you start to talk about long COVID, everybody has a little bit different idea of what that is, but international meetings of virologists have decided that if you're still having significant symptoms that are impacting your life at 12 weeks or longer, then that by definition is a long COVID. Goes by other names, post-COVID-19 syndrome, probably the one you'll see most commonly, but everybody's talking about symptoms that persist for 3 months or longer. And this is not unprecedented. There are other viruses that do this. If you think about mononucleosis, a fairly common illness that many people have either had or they know somebody who had it. And it's not uncommon for that to last for 4 weeks with sore throat and fatigue, and people sort of slowly get over it. And occasionally they have symptoms that persist long after that. This is also very similar to people who are in the intensive care unit for any reason. If you have a heart trouble or lung trouble or whatever, and you wind up in intensive care for a significant amount of time, people report very similar symptoms that last for months following that. Or if you have sepsis, an overwhelming bacterial infection, and sepsis often leads to prolonged symptoms. Next slide. So how many people get long COVID who have had COVID? Again, the numbers are hard to come by, but there are some studies that have looked at Europe and the Western countries and have come up with an average of around 6%. So of those who get COVID, about 6% have symptoms that last for a long period of time, 3 months or more. Now, out of that 6%, there's a predominance of females. They seem to have more trouble with long COVID than males by a factor of about 2 to 1. And it is true that the older you are, the more likely you are to have long COVID. It's also true that if you have other significant chronic illness, you are more likely to have long COVID. And by chronic illness, it involves pretty much any organ system you can think of: chronic lung disease, heart disease, kidney disease, any kind of GI trouble, any kind of immune compromised situation, hematologic blood disease. Any of those will raise your risk, even if you're under age 65. And how do we diagnose it? Well, the most common symptoms are fatigue, far and away. And this is fatigue where people, they're not just tired, they have trouble getting out of bed in the morning. They have trouble getting through a day of just average activities of daily living. So significant fatigue. Shortness of breath is very common. A chest discomfort, usually people describe it as there's tightness in my chest. I feel like I just can't get a deep breath. And then chronic cough. Those are all the most common symptoms. And then after that, it's almost anything you can think of. But anxiety, depression, those are common. Memory problems, troubles, getting lost, troubles remembering common things that you should know. Changes in taste or in your sense of smell. And then there's this POTS syndrome, which I was aware of before COVID ever came around, but associated with streptococcal infections, and it was pretty rare. But now it's not that rare, and this is postural orthostatic tachycardia syndrome, which in the short version means getting dizzy when you stand up. Dizzy because your blood pressure drops and your heart rate goes up. And this has to do with our autonomic nervous system not functioning normally after it's been infected with COVID. And all sorts of other things: skin changes, itchy skin, just about anything you can think of, visual disturbances. And then next slide. How is it treated? Well, first of all, you have to make sure that's what it is. So my best advice is go see your primary care provider to start with if you've had COVID and you feel like you're just not getting over it. And you don't need to wait until the 12 weeks, but if it's 4 or 5, 6 weeks and you're still having significant symptoms, it's worthwhile to go see your provider to get a workup to make sure that there isn't something else going on, or that there isn't some clear-cut damage from COVID. Things like development of chronic obstructive pulmonary disease, or development of maybe a heart rhythm disturbance, development of blood clots. We know that if you have COVID, you are prone to blood clots. So there are lots of other changes that COVID is at the root of. But the first thing is to go and make sure that this is long COVID. There are some treatments, the same treatments that are used for the initial infection, which are antivirals, are being used in long COVID. And they certainly aren't wonder drugs. They don't cure everything or make you feel like a brand new person, but they do seem to help you get over it. And as I said, fatigue is one of the main things people complain of. And there, unfortunately, isn't any great treatment for that. Rest is probably the most important thing that you can do. And then the people who are seeing most of the long COVID patients, especially in older patients, are saying they've developed this 4 Ps treatment, which is, first of all, planning your day. Realistically, what am I able to do? Realistically, what do I feel like I'm up to doing? And then pacing yourself with intermittent rest periods through the day, prioritizing what are the things that I most would like to get done today, or that I most would like to do today. And then positioning. Do I have to be standing? Are there things that I enjoy doing that normally I would stand, but I would be better off if I were to do this sitting or reclining? So those are some of the things that people are talking about treatment. Next slide. So we don't have a lot of great treatments, but your primary care person can help you with advice on what you can do to get to feel better. More importantly, how can we prevent getting long COVID? And obviously, the most important thing is don't get COVID in the first place. Make sure that you're vaccinated. Stay away from people who are ill, especially if you know that they have COVID. Hand washing, and yes, wear a mask. When you look at news anywhere, but especially internet news now, they're saying, oh, masks have been debunked, and that simply is not true. That comes from a study that was looking at, was masking effective in the long run over a huge population of reducing the incidence of COVID. And it did not appear that there was a significant impact, but that's because not all of those people were wearing their mask all the time. Most of those people they were associating with were not wearing a mask, and people just weren't doing it. And so, of course, it didn't show any big improvement. But when you look at small populations, carefully controlled studies, it's very clear that masks work. And this is not rocket science. Since the early 1900s, surgeons began wearing masks, and they found out, lo and behold, they weren't infecting their patients while they were operating on them. And when's the last time you wanted to have your appendix taken out by a surgeon who wasn't wearing a mask? Common sense will tell you that masks work. So wear your mask, especially if they're going to be in a confined space with lots of people, or when you're going to be around somebody who you know is ill. Wear your mask. When we talk about vaccination, even if you've had COVID, it's still worthwhile to get vaccinated. We know that vaccination reduces the incidence and the severity of long COVID. So that's a good reason to get the vaccination. We also know from research that the more times you get COVID, the more likely you are to then suffer from long COVID. And, a lot of people have been infected once with COVID and then gotten infected again. And some people are even on their third or their fourth bout with it. As these new variations keep coming around, your immune system doesn't necessarily protect you from all of the new variations. And vaccination is the best way to protect yourself and the best way to protect yourself from long COVID. Next slide. Well, that is my short, brief talk on long COVID. If there are any questions, you can send them to me in the chat, or you can get a hold of me at Mountain Pacific, D. Kunzweiler at mpqhf.org. And thank you very much, and I will turn it over to Brittany Hall.
Thank you. Hi, everybody. My name is Brittany Hull. I've been a life enrichment coordinator for about the last 8 years. I've been in long-term care for a really long time. And so I was asked to talk about how activities can help with the elders in our communities, helping them cope with that, helping kind of make them feel better, maybe lessen some of those symptoms, all kinds of good stuff like that. Next slide, please. Same thing. A lot of the symptoms of long COVID are a lot of the same things that some of our elders suffer from just because they're older. Maybe they have some underlying medical conditions, lots of different things like that. But these are some of the ones that kind of pertain to activities and the things that we can kind of hit on or help with. Even though the elder or the community member may not be in an activity for us to help them, things like giving them tools or helping them get used to using tools to help with hearing loss or fatigue, helping them learn how to kind of cope with some of their anxieties, different things like that. Sometimes we can help give those tools to the other staff, nursing staff, even in the dining room. just help them learn to utilize those tools. Next slide. Some of the things with the team that I was working with during COVID, when a lot of places were on lockdown and you're trying to do everything you possibly can to make their life as interesting and normal as possible, these are kind of my 3 big points. Working with their natural sleep schedule. We all feel better, or at least I do, when you don't have to wake up in the morning to your alarm clock. If you get to wake up to your own body telling you you're ready, you feel better. And that helps decrease depression, anxiety, helping them stick to their natural sleep schedule, also helps with insomnia. As you get into community members who struggle with dementia or Alzheimer's, having that regular sleep schedule helps a lot. When you start talking about the 4 Ps, working with planning and prioritizing, for them, a lot of people, especially after COVID, and I'm sure you guys have seen it too, they struggle to want to be out of their room. They struggle to branch back out, even if they were things they enjoyed doing before. It's hard to get them to re-engage in those things. So starting with small groups, maybe one of your life enrichment staff, or maybe a CNA or another member of your administrative team takes a minute and builds that bond with a resident, helps them branch out, feel a little more comfortable in a small group activity, and then you can start working them into those larger group activities. That way they don't feel so overwhelmed or so overstimulated by what's going on in the room. Because if you've been by yourself or with just your roommate for the last 2 years, getting out and being a part of bingo, which is really loud and really crazy, is hard. So maybe doing, small games of Yahtzee or Scrabble, or having a knitting circle, just having a coffee clutch, make a really big difference if you can start there and then move forward. Having your next slide, please. Having your teams come together to do what's most effective for your elders is best. I know a lot of places you want the nitty-gritty staff in your rounds in the morning, because you don't want to spend all day in there, but including a life enrichment staff member can give you some perspective, can help you ask the questions that need asked, that maybe that CNA or the nurse are in there every day with that resident and they're kind of at baseline. But your life enrichment people can help you realize that, hey, Sally hasn't been as active. She hasn't she hasn't been coming out to the coffee clutch. She hasn't been in the canasta group. And she used to lead the canasta group or be very active in that coffee clutch. And she hasn't. Or I've had a resident who was relatively nonverbal, but with her, with one of the activity staff, she was really close, and they would come in and she would have small conversations with that person. No one else was really even aware she could speak, because she didn't interact with her nursing staff in that way, or with the nutrition staff in that way. But activities was able to kind of draw her out, because it's a different environment, because it's a different person, and it's a different interaction. So making sure that you include those staff members in your meetings, just so that you have that different perspective. Activities tends to ask the question, what can this person do? How can we make this work for them? I included the picture of the the crochet hooks, because sometimes you can slip a tennis ball over a handle of a crochet hook and they can all of a sudden use that because they can grip it differently. Buying huge or making great big Scrabble tiles so that they can see them. AirPods work really great as a temporary hearing aid for someone who may not have them or can't afford them. They work really well in that in that space. Larissa's asking about working closely with social services, and your life enrichment team in your social services department. I know I've had the opportunity to work with Larissa at a different community. Those two departments work very closely together. They should be, coming in almost together and blending to make sure that those residents get all of the care. Social services can come in with themselves or counselors from outside or whatever other personnel make your elder comfortable, and helping provide those tools so that the resident gets everything that they need, and not just the ADLs, or the meals, or the bingo, the bright and shiny things that everybody thinks about when you think about elder care. Making sure that we can come together as a whole and serve them the best we can. That is all I have. Do we have any questions?
Thanks, Brittany. If you guys have any questions for either Brittany or Dr. K, feel free to come off mute and ask them live, or if you want to go ahead and type them into the chat box, you can do it that way. But thank you very much to both of you for presenting today.
You're welcome. That was fun.
Thanks for having me.
Dr. K, do you have anything to add about activities or anything like that? Not to put you on the spot, but.
Well, the one thing I know for sure, the more active you are, the healthier you are and the happier you are. And the old adage of use it or lose it is really, really true. I've experienced that in my own life. So the more activities you can do, the sharper your brain will be, the better your body will work, and the happier. So I'm all for doing as many activities as you possibly can.
Nice. Mary, we can go to the next slide. Larissa has a question. How about culturally relevant activities? Can you speak to that? Brittany?
Yes. So culturally relevant. Larissa, are you talking about like specific culture activities, or like culture change and those kind of activities?
Hey, Brittany, can you hear me?
Yep.
Okay, perfect. I was actually thinking on both sides because I think so there's a huge, attention being, focus, I guess, being put on the cultural change, and we all know how important that is. But how is that relevant to the patient-centered care, as well as if you have a community member who is part of a specific culture, bringing those, paying attention to what is relevant, again, as patient-centered to that community member. That's kind of what I was thinking about on that
Gotcha.
importance.
So culture change, especially in Wyoming, we just started our culture change coalition, helping push not only resident-centered care, but resident-directed care, putting them back in the driver's seat for their own cares. Sounds very scary, but that is a large number of small steps that help put the residents in the driver's seat and give them back the decision-making power, whether that is, your community council dictating what kind of activities they would like to see on the calendar, whether or not they would like to lead those activities, what kind of meals you serve in your dining room, all kinds of different things like that. We're healthcare, elder care is trying to move in this direction, that it's no longer resident centered care, it is resident directed care, giving them the ability to make those choices, and be as much a part of their own daily life as humanly possible. So activities, especially, we're no longer just entertaining them, but you are trying to include them and fulfill their lives rather than just, let's play bingo, let's watch a movie, let's go to the museum. Now it's, hey, we're going to all make lunch. So you have residents go in and help prepare and serve those meals. You have residents who help fold and distribute laundry if they so choose, or help with small repairs with your maintenance crew, whatever it is that makes that resident feel like they're contributing to their community. And maybe that's not for everybody, and you have people who still just want to play games and hang out. That's fine too. But are they interested in leading that group? Can they lead the exercise group? Can they do the tour at the art museum when you go? Whatever it is that makes the resident feel comfortable and as though they have a bigger position than they do currently.
Thanks for that, Brittany.
Yeah.
Doesn't look like we have any further questions in the chat, and we are at the end of our webinar. So Mary, can we go to next slide? I want to thank everybody for joining us this week. Mary did pop the evaluation into the chat, so if you guys can fill that out for us, we'd really appreciate it. And then we hope to see everybody back next week. We will have Jennifer Chikoyak from American Lung Association of Alaska, and she'll be presenting on, I believe it's tobacco or smoking cessation in nursing homes. So we would really appreciate you joining us next week for that presentation. So I want to thank Brittany and Dr. K again, and thank you so much for sitting on this with us, and we'll see you next week.